Okay, so I'm on the affirmative side, and I'm going to be talking to Chris's points a little bit. First, he stated that euthanasia, if it's legalized, that'll lead to more cases of euthanasia, and it could lead to non-voluntary euthanasia. So in response to that, in order for that argument to be valid, the evidence is needed. R.G. Frey wrote in a book, Euthanasia and Physician-Assisted Suicide, For and Against, that we need the evidence that shows the horrible, slow consequences are likely to occur. The mere possibility that such consequences might occur, as noted earlier, does not constitute such evidence. So if we take a look at the evidence, there's some numbers from the Netherlands that don't reflect this slippery slope trend. Morris M. wrote in an article, The 10 Arguments for Legalizing Euthanasia, that in the Netherlands, only 1.7% of all deaths are from euthanasia, and the Netherlands system has made it complex, bureaucratic, and difficult to achieve. And around 2/3 of the patients who apply to be euthanized are refused. So you can't make the logical connection to justify the argument, because physician-assisted suicide is in the hands of the patient. The patient makes the decision that they want to receive this. So it's implausible if one who makes the argument means that there's a logical connection between the likings in question, such that one who endorses the first cannot without inconsistently refuse to endorse the last. The fact that in one case a person is killed in his own interest because he requests it, whereas in the other a person is killed in the interests of others without his consent. So there's a morally relevant difference there. So you can't make the connection to justify the slippery slope. And that was a statement from Derek Humphrey in an article, The Case for Assisted Suicide and Active Voluntary Euthanasia. He also made a statement that the government may issue statements that all infants or people with disabilities should be euthanized. And this is false. Euthanasia doesn't target the vulnerable. Morris M. wrote in an article, 10 Arguments for Legalizing Euthanasia, that in 2007, the Journal of Medical Ethics analyzed the cases of every single patient who opted for the services and found poor, elderly, minority, or otherwise vulnerable groups were represented as infrequently as everyone else. So in other words, the vulnerable were no more likely to receive assisted death than anyone else, and white men were the primary users of the service. Going on to Chris's second point, that patients are not suffering, he said it's easier to use pain medications than to go to the option of euthanasia. I would like to state that pain medications can't relieve some suffering. Julian Off wrote in Euthanasia Relieves Suffering that even with the state-of-the-art palliative care, many terminally ill patients will experience substantial physical and existential suffering. It should also state that it's a myth that palliative and medical care can relieve all the suffering associated with the advance of diseases like cancer, AIDS, and motor neuron disease. So to give you guys some context into some of the illnesses that result in these pains that can't be cured by palliative care, Julian Off stated that pain, particularly due to infiltration by cancer of extremely sensitive nerve-rich areas such as the head, neck, pelvis, and spine, is commonly episodic and excruciating, aggravated by movement, and is not adequately controlled by palliative medicine. Due to the inconsistency of these pains and just their cause from random movements, you can't predict when they're going to happen, so you can't keep a patient medicated all the time. Some other examples include inoperable brain tumors, lung cancer infiltrating the root of the neck or chest wall, which comes in contact with very sensitive nerves, and mesothelioma, which is pain with each breath. So non-pain symptoms can occur as well. So cachexia, commonly associated with advanced cancer, involves severe loss of appetite, weight, loss of energy, and severe distress. So psychological pain due to gross debilitation and loss of independence. So these are many other forms of suffering that can occur that euthanasia would solve. So if you think that the numbers of people that's suffering aren't significant, that's not true. So American Cancer Society stated that 13 million people in the United States have been diagnosed with cancer. And it says that around 5 to 10% of cancer is accompanied by these intolerable symptoms. which is equivalent to 650 to 1,300,000 people, which in terms of suffering is a lot of people. To address the last point that it destroys the doctor-patient relationship, Peter Rogratz, a medical doctor, wrote in The Positive Virtues of Physician-Assisted Suicide, he stated, "I have spoken with a great many people who feel they would like to be able to trust their physicians to provide such help in the event of unrelieved suffering, and making that possible will give such patients a greater sense of security." So it makes the patients feel better that they at least have this option if they're suffering intolerably, that they can rely on euthanasia to help that. Another statement from Linda Ganzini from the Oregon Physicians' Attitudes About Experiences with the End of Life Care since the passage of the Oregon Death with Dignity Act. She stated, "Doctors who oppose euthanasia were more than twice as likely to report a patient becoming upset or leaving their practice as a result of their position compared to the physicians who supported euthanasia." So they're more than twice as likely to lose patients because they don't support euthanasia, they don't have that option, so the patients will move to another physician. Another statement I'd like to make is that he said that patients will somewhat distrust their doctors and fear the patient-doctor relationship. Well, Peter Rogratz wrote in Positive Virtues of Physician-Assisted Suicide and The Humanist in 2001 that patients are not lying in bed wondering if their physicians are going to kill them, since the act of administering a fatal dose would be solely within the control of the patient. So the regulations placed on known cases of physician-assisted suicide in Oregon and other countries have proven that it's not going to fall down a slippery slope and turn into non-voluntary euthanasia, and that there are actual patients out there suffering that palliative care can't control, and that the patient-doctor relationship actually improves due to the acceptance of euthanasia. Thank you.